We are now recording.
Thank you very much. So good morning. My name is Kathleen Borain, and I serve as the Maryland Insurance Commissioner. And on behalf of the Insurance Administration, I'm very pleased to welcome you this morning to the Administration's first virtual public hearing on the mental health parity reporting regulations that we will adopt by December 31st, 2021. Let me take a moment first to address some housekeeping matters. First, as is the case all over the world, this is a virtual hearing. It is being held via the WebEx events platform, and it is being recorded. The video and the sound recording will be made available on the MIA's website within the next few days. Second, only those individuals who received a participant invitation and who have accessed this meeting through that specific link and invitation can be seen or heard. In addition to me and my staff, links were sent to the individuals that we identified in the MIA's hearing notice and to anyone who requested to speak in advance. If you fall into that category, that is, you requested to speak in advance or you were invited to speak by the MIA, but you have not been able to log in, please let us know that via the chat feature, or if you are on a phone line, by emailing us at the email address that's on the screen. That is craig.ey@maryland.gov. So if you were already signed up to speak and had gotten confirmation of that, and you're having trouble getting in, please let us know in the chat function, or please let Mr. I know. Third, even if you did not sign up in advance to speak, but you wish to be heard, please let us know that also via the chat function or by sending an email to that same address on the screen, craig.ey@maryland.gov. If you will provide us with your name and affiliation, that would be very helpful. When we have heard from all of the scheduled speakers, if we have time, we will hear from those who indicate that they want to be heard. And just as a reminder to everyone, if you are participating, please mute yourself unless you are speaking. So with me today from the Maryland Insurance Administration are Erica Bailey, the Associate Commissioner for Compliance and Enforcement, David Cuney, Associate Commissioner for Life and Health, Michael Patty, our Director of Government Relations, Mary Quay, our Chief of Life and Health Insurance Complaints Unit, and Craig I, our Director of Communications. As noted, we are here today regarding mental health parity reporting regulations. During the 2020 legislative session, the MIA worked very closely with insurance carriers, members of the General Assembly, and advocates regarding the oversight and enforcement of the Mental Health Parity and Addiction Equity Act that was passed by Congress in 2008. As a result of those significant collaborations and cooperative efforts, House Bill 455 was adopted. The bill amended Section 15-144 of the insurance article to, among other things, require carriers to submit reports to the Commissioner to demonstrate carrier compliance with the Parity Act. The law also requires the Commissioner, in consultation with interested stakeholders, to adopt regulations to implement the law, including regulations that ensure that the reports are based on uniform definitions and methodologies. The Commissioner also is required to develop a reporting form. The uncodified language of the law provides that, and here I quote, that the form, quote, shall be the National Association of Insurance Commissioners data collection tool for mental health parity analysis, non-quantitative treatment limitations, and any amendments by the Commissioner to the tool necessary to incorporate the requirements of Section 15-144C, D, and E of the insurance article. Now, we are going to have many hearings and opportunities for public comment as we go through the process of developing our regulations. Today, specifically, we are looking at which, non-quantitative treatment limitations, NQTLs, are most appropriate and precise for demonstrating parity compliance as the first step in assessing whether amendments to the NAIC data collection tool are warranted. And to that end, today we are going to start with experts concerning studies that have identified, or what studies have identified regarding parity, or more precisely gaps in parity. and recommendations as to the NQTL that will best satisfy the substantive reporting requirements of Section 15144. So our first invited speaker today is from Milliman, which has conducted national studies and studied multiple reports and issued white papers evaluating mental health parity. With us from Milliman is Stoddard Davenport. Mr. Davenport helps lead Milliman's behavioral health and population health teams. We invited Mr. Davenport here to share the results of Milliman's analyses of NQTL limitations associated with behavioral mental health care services and the disparities noted in the reports published by Milliman respecting those analyses. Mr. Stoddard, welcome. We are very happy to have you with us today. We are most interested in hearing from you.
Thank you for the introduction, Commissioner. Appreciate the opportunity to be here and share a little bit of what we've done in this area. So to start, I'll go ahead and give a little bit of backdrop here. So as the Commissioner stated, I'm a healthcare consultant and researcher with Milliman. Mental health parity has been
Mr. Stoddard, hold on just one second. I just want to ask you if you could maybe increase your volume just a little bit. I know I'm having a little bit of difficulty hearing you. I don't know if that's true for anybody else.
Sure. Is this any better?
Yes, thank you so much. I want to make sure we capture you well in the recording.
You bet. Yeah, so mental health parity has been a significant focus area for me and my team essentially since the law went into effect. And just to sort of briefly outline our experience here, we've been supporting health plans with evaluating their plans for compliance for years now, and have done the quantitative testing for health plans to measure compliance for thousands of plans at this point. And we've also put a significant amount of effort into research and publishing and speaking on the law and doing analysis of the impact that it's had within the healthcare market. And we've been advising health plans and regulators on their approaches to monitoring for compliance for non-quantitative treatment limitations as well. And if you could go to the next slide. Just to make sure we're on the same page with kind of the components of the law, the rules in the Mental Health Parity and Addiction Equity Act break down into kind of two broad categories, those governing quantitative treatment limitations, those governing non-quantitative treatment limitations. For quantitative treatment limitations, the law stipulates sort of black and white mathematical tests that can be used to evaluate compliance with technical terms, but these govern things like co-pays, co-insurance amounts, deductibles, visit limits, things like that are relatively straightforward to evaluate in a quantitative fashion. Non-quantitative treatment limitations includes other processes, standards, policies, et cetera, that may limit behavioral health care. For example, prior authorization, medical necessity criteria, provider payment rates, network adequacy, et cetera. There are dozens of potential limitations to consider. Within the regulations, these have traditionally been more of a gray area. There are not sort of precise mathematical definitions for how these should be evaluated, but the law does stipulate that any limitations applied to behavioral care should be comparable to and no more stringent than those applied to medical surgical care, both as written and in operation. And those are sort of the governing principles for non-quantitative treatment limitation analyses. Next slide. So we were engaged by the Mental Health Treatment and Research Institute, a not-for-profit subsidiary of the Bowman Family Foundation, in 2017 to complete a study on a couple of the non-quantitative treatment limitations that are amenable to quantitative analysis using administrative claims data. That at Milliman we have access to substantial claims data resources. So we completed a study of claims data for tens of millions of individuals and focused on a couple of particular areas. We updated that report a couple of years later in 2019. So last fall was the update that we issued, focusing on out-of-network use, in particular disparities in out-of-network use between medical and behavioral health care, and provider reimbursement rates, focusing on disparities in provider payment levels between medical and behavioral health care providers. So these are kind of the two out of the many potential non-quantitative treatment limitations to consider that we were able to sort of assess at scale using the claims data resources, which are typically readily accessible to folks administering health insurance plans. Next slide. So to highlight some of the key findings, I'll go through a few highlights here, and then we'll kind of take a little bit of a deeper dive in a few specific areas. So first of all, we found that inpatient out-of-network care for behavioral health was 2.8 times more likely than out-of-network care for physical health in 2013. And that increased to 5.2 times more likely for behavioral care than for physical care in 2017, representing an 85% increase over the duration of time that we were able to study. We found that out-of-network disparities worsened in each of the categories of care that we examined between 2013 and 2017, and that use of out-of-network office visits for substance use disorders was 9.5 times more likely than for primary care in 2017. We also found that for children, their use of out-of-network office visits for behavioral health care was more than 10 times as high as their use of out-of-network care for primary care. Next slide, please. When we look kind of, this chart gives sort of the broad picture over the four categories of care that we examined over 2013 to 2017. We've highlighted in blue the years of data that we presented in our original 2017 report, and in orange the additional new findings that we added on in our 2019 study. And our analysis focused here on inpatient facility care, outpatient facility care, and then office visits as compared to both primary care and medical surgical specialists. And again, you can sort of see this pattern where, particularly for facility care, there's sort of a clear and distinct worsening of disparities over time. Primary care and specialty care office visits, we still see things being worse in 2017 than in 2013, but a little bit less dramatic than we noted for facility-based care. Next slide. So moving on to provider payment disparities, in 2017, we found that primary care providers for medical surgical care were reimbursed at rates that were on average 23.8% higher than rates for behavioral health office visits compared to Medicare fee schedule amounts. And just to describe this a little bit more, of course, different types of providers may provide different types of care, but we use Medicare fee schedule amounts as sort of a common benchmark for understanding how fee levels tend to vary. And Medicare fee schedules are certainly not universally used, but commonly used in the health insurance world as part of the process of setting and benchmarking and understanding relative fees for different types of services. So this sort of gives us a benchmark for comparing different baskets of services against one another. During the 5-year period that we studied, reimbursement rates for behavioral health care were consistently below Medicare allowed amounts, and disparities for substance use office visits were different from those for mental health. If we can go to the next slide, we can see this in sort of a visual format here. So in this chart, we're sort of displaying how payment levels for primary care office visits, medical surgical specialty office visits, and behavioral health office visits compare to the Medicare fee schedule amounts for those same services. And you can see that payment levels have been increasing over time, but the gap has been fairly consistent between behavioral and medical surgical care in each year. And you can see that again if you roll forward to the next slide, that for compared to primary care providers, primary care providers have been paid, anywhere from 20 to 23, 24% higher than behavioral health care providers relative to Medicare fee schedule amounts, and then sort of in the 17-18% mark for medical surgical specialists compared to behavioral health care providers. Next slide. And so I think when we talk about how much that health plans are paying for behavioral health care providers, just to put that in context, we also quantified what does total spending on behavioral health look like compared to healthcare spending overall. And we found that spending for mental health treatment, so the healthcare focused on mental health specialists, et cetera, excluding prescription drugs, ranged between 2.2 to 2.4% of total healthcare spending during the 5-year period that we studied. And then spending for substance use disorder care, again, excluding prescription drugs, ranged from 0.7% to 1.0% of total healthcare spending during the 5-year period. So again, this is sort of, just to frame this, that behavioral healthcare tends to not be, a large proportion of healthcare expenditures when we think about sort of the impact of different rates and things like that. Next slide. So as part of the analysis that we completed, we not only completed our analysis at the national level, we also took a deeper dive and studied the results for each state individually as well, and compared each state to the national average. And here we'll highlight a few of the specific findings for Maryland. So first of all, looking at behavioral health office visits, we found that 31.7%, nearly a third of behavioral health office visits were out of network in 2017 in Maryland. That was 10 times more likely to be out of network than primary care office visits. And that's a disparity that's nearly twice the national average. And that ranked 4th worst in the United States as of 2017. Next slide. For behavioral use of inpatient care, we found that just over a fifth, 20.2%, was out of network in 2017. The disparity there grew from behavioral health care being 5.5 times more likely to 9.3 times more likely to be out of network than physical health between 2013 and 2017. And again, this is a disparity that was nearly twice the national average. Next slide. For use of outpatient facility care, 28.2% of behavioral health visits were out of network in 2017, and that was an increase from a disparity of 2 times to 3.6 times more likely to be out of network than physical health care between 2013 and 2017. So we're again seeing this sort of the disparity growing over time in each instance. Next slide. So for provider reimbursement, we found that in Maryland, behavioral health providers were receiving 18% less than primary care doctors relative to Medicare fee schedule amounts for similar billing codes. Next slide. And just to sort of put some takeaways on this. So we found that disparities in network use and provider payment rates are present and are substantial and are widening, both at the national level and within Maryland specifically. So this is something that we keep an eye on, and that, in the interest of providing good quality behavioral health care, are somewhat concerning both in the context of mental health care parity compliance and even outside of the context of parity compliance. These are just concerning generally to see happening in our behavioral health care delivery. But these disparities that we observed are not isolated to just one part of the care continuum or to one part of the country. We see these, they're widespread across all levels of care and all around the country. But I do want to highlight that, according to the regulations for mental health parity, disparate results do not by themselves constitute non-compliance with Mental Health Parity and Addiction Equity Act, but do indicate areas that warrant further inspection. And to sort of further underline that, we did see that the Department of Labor, which has regulatory authority over self-funded employer-sponsored plans, they produce a self-compliance tool, and in the latest iteration that they released this year, specifically added a section on potential warning signs that warrant further inspection, and specifically listed disparities in out-of-network care and disparities in provider payment rates as a couple of areas that they suggest really ought to create the need for a deeper dive. And, as I touched on at the beginning, it can be challenging to evaluate non-quantitative treatment limitations for compliance, but there's sort of this stepwise comparative approach that's really coming to prominence over the last few years. There's been regulation and guidance and tools available for a number of years now, including the 6-step parity compliance guide, as well as the Department of Labor's self-compliance tool. And I think those may be touched on more separately, but those sort of provide the framework for how you would walk through an analysis in a sort of rigorous fashion to understand where disparities exist and are outside of what would be justifiable under the parity rules. And with that, I want to thank you for the opportunity to share our research findings, and that's all I have for today.
Thank you very much for that very thorough presentation. Very much appreciated. Is there anyone from the Insurance Administration that has questions for Ms. Okay. Hearing none, I just want to take a second to acknowledge the fact that Senator Eckert, Senator Augustine, and Delegate Colson from the General Assembly are with us today. And they had not, I know that they are listening in on the hearing. So Senators and Delegate Colson, if you wish to be heard, we would very much like to give you the opportunity to speak, if that's something you would like. If you just identify or just let us know in the chat room, or if you want to send an email to Mr. I, we'll make sure that we add you in as a participant so that we can give you an opportunity to speak to this issue. So in the meantime, we are also fortunate to have with us this morning representatives from the Path Forward for Mental Health and Substance Use for the Mid-Atlantic. The Path Forward has embarked on a 5-year plan to execute a first-of-its-kind private sector approach to improve mental health and substance use care for Americans across the nation, primarily through employer engagement. There are 5 priority strategies to transform behavioral health care at a population level, includes ensuring mental health parity compliance. Today, we will hear from John Miller, the Executive Director of the Mid-Atlantic Business Group on Health, and from Linda Raines, the CEO of the Mental Health Association of Maryland. Mr. Miller and Ms. Raines, welcome. Happy to have
Thank you.
this morning.
Thank you very much, Commissioner Ray. I appreciate being here. This is John Miller. I am Director of the MidAtlantic Business Group on Health. MABGH is a regional coalition of large companies that are purchasing health care on behalf of their members, that being their employees and dependents. They are represented with our group by folks, generally speaking, in human resources, and more specifically, frequently, in the benefits department of the human resource department. In other words, the people who make decisions about what insurance carriers they'll be going with, what the plan designs will look like, and so on and so forth. So that's our membership. The purpose of our organization is to help those members maximize the value of their healthcare spend. That takes two forms: getting the best possible health care and managing the cost of that health care as well as possible. And we find that, generally speaking, those two things are not exclusionary, but rather are complementary, and that accomplishing one accomplishes the other also. So that's the basics of the MidAtlantic Business Group on Health, and that's who I am. We are a member of the National Alliance of Healthcare Purchaser Coalitions. You can squint and see at the bottom left-hand corner of that slide is the logo of the National Alliance. That is a coalition of coalitions like mine. There are about 45 of us across the country, and we are one of those 45 coalitions that are members of the National Alliance of Healthcare Purchaser Coalitions. This particular initiative, the Path Forward, you'll note is a partnership between the National Alliance, other large employer-type groups, some provider side, the American Psychiatric Association, foundations, so on and so forth, not least of which is the Mental Health Association of Maryland, who is joining me on the call in a few minutes. So that's who we are. Next slide, please. We'll be talking today about 5 strategies that this group is putting together to try to improve access to good quality behavioral health and substance abuse assistance. And I will start with the upper left corner there, which is improve in-network access to behavioral health providers, which I think Stoddard just very, very well detailed out the challenges we're seeing in that area. And for my members, those challenges are not just statistics or data. Rather, there's someone who has come into the office of the benefits manager to say, I'm really trying to get behavioral health assistance for my son, my 17-year-old daughter, I myself, or someone, and we're having extreme difficulty getting access to someone in the network, getting them into treatment. And if I can't get into treatment in the network, then my expenses go way up, and I don't know if I can even access behavioral health. As you can see, this creates a sort of a have and have not sort of an issue, which is heartrending for my members who are behavioral, the benefits folks within companies. So that's their real direct experience with this, and that's their real pain point in the behavioral health system. The other things that follow are things that have really been recommended to us by experts in behavioral health services as ways for us to mitigate that pain. So in order to improve in-network access to behavioral health providers, Health Parity will assist with that. Paying providers more will encourage them to be in-network providers. So there's an example. Expanding integration into the collaborative care model is an evidence-based approach to improve access to quality behavioral health. Include improving use of telebehavioral health. Needs to say no more. Measurement-based care is an approach that our experts have told us, and with evidence, that will improve the quality of the care that those folks receive. So if you look to the quick right of that, each of these improves outcomes and cost efficiencies, and each has been endorsed by accrediting bodies, by provider groups, and by payers. So these are evidence-based approaches. the National Alliance and the MidAtlantic Business Group on Health are all about evidence-based medicine, and these approaches have been backed up by evidence. Ergo, we're confident and comfortable in endorsing this approach to improving access to high-quality behavioral health. Next slide, please. But we know that this is not something that we can drive through, that we can make happen. This really requires the participation, the active engagement of a number of different types of stakeholders. Therefore, the name of this organization, this initiative, which is a RESET region, we are called RESET, that stands for Regional Employer Stakeholder Engagement Team. Our true function is to bring together these folks to engage and align in a way that will result in better access to high-quality care. As you can see, we're looking for participation with behavioral health providers. Primary care is so important because so much of care is delivered in the primary care setting. The payers, of course, that being health plans, us, the employers, states, benefits consultants are crucial to this effort. So many purchasers follow the advice of their benefits consultants that it's necessary that they really be on board and help us move this forward. State and health and federal regulators and policymakers, the more we can be aligned with all of these folks, the smoother the path will be. Behavioral health advocates, medical societies, philanthropic organizations, there are a number of different types of stakeholders that we're aligning to move this path forward. Next slide, please. Just to detail out, and I will not go through the list, but this is a short list of the sorts of groups that we've brought together on a national level to look at this program and move it forward. So on the upper left, you'll see a number of the business groups that are a part of the National Alliance are associated with this. Beyond the rest of the list is behavioral health organizations, starting with the American Psychiatric Association and a whole list more. So this is founded and promoted and driven by the purchaser side, also by the provider side. Next slide, please. I think importantly, it's worthwhile that I point out that on a national level, we are partnered with the HR Policy Association and their related organization, the American Health Policy Institute. I point this out because the HR Policy Association is a group that represents over 375 Fortune 500 employers, several of which are co-located in the state of Maryland and are members of ours and or members of the HR Policy Association. Two examples that come off the top of my head, Marriott and Under Armour, for example, would be members of that organization who are located in Maryland, but there are more. So this group also helps us move forward on a national level as well as locally. Next slide, please. So I'll just take 1 second to point out that we are one here in Maryland. We are one of 8 RESET regions across the country that were selected after application by the National Alliance to lead the way, test the water, and show the way this can work to the rest of the coalitions across the country. You'll see that the 4th one down there is MidAtlantic Business Group, Maryland, D.C., and Northern Virginia. But we are one of a number of coalitions across the country that are driving this effort forward officially. That's not to say that other coalitions in the country are not working toward the same goals. They are just not designated as RESET regions, as the MidAtlantic Business Group on Health is designated as one of those regions, which we're thrilled about. Next slide, please. And finally, to just begin to delve into our local efforts, in the Mid-Atlantic region, we have formed a partnership, and it's really hard to say which one of these groups is the primary partner of this group. I suppose perhaps the Mid-Atlantic Business Group is, but it doesn't feel that way. We have joined with the Mental Health Association of Maryland and Linda Raines, who will also be on this call. Our third partner is the Maryland Primary Care Program and Howard Haft, who leads that group for the state of Maryland. The Maryland Primary Care Program has over 450 practices enlisted in their organization. They represent over 2,000 physicians. The purpose of that group is to advance primary care in the state of Maryland, and an important component of that is incorporating behavioral health collaborative care practices, which we are champions of, into primary care. So our interests are perfectly synergized and aligned. The Mental Health Association of Maryland, an advocacy group representing all the mental health advocacy organizations in the state of Maryland, over 100 years old. I will toot Linda Rain's horn for her for just a moment, was instrumental in enacting one of the first mental health parity laws in the nation here in Maryland in 1993. So it's a strong history, excellent connections, and our three interests are perfectly aligned, and we believe they'll also align with the interests of the providers in the state of Maryland and the health plans in the state of Maryland, and we hope the state of Maryland agencies as well. So that's who we are. I'll turn this over to Linda for a few minutes. Linda, if that's okay with you.
Yes, thank you, John, and thank you, Commissioner Berain, for inviting us to present today. I want to start by saying a few words about what I think is unique about the approach of the path forward.
Ms. Rains, I'm sorry to interrupt, but I am having a little difficulty hearing you.
Is it volume?
That's a little bit better. Yeah, it's the volume.
Is that better?
Yes, thank you.
Okay, great. Well, I'd like to start by saying a few words about what I think is unique about this initiative. Most of us in this meeting have spent our entire careers working to improve healthcare, and it's not uncommon when we find ourselves at odds with different sectors about what those best solutions are. So to me, this project really represents a different approach of bringing key sectors together to find common ground on the issues. Dan, can you go to the next slide? And here's a list again. I won't read them all, of the various groups that are part of this MidAtlantic launch. You'll see the first group is employers in the state of Maryland, some large, some small, some of the major healthcare consulting organizations that consult to employers, our state agencies, a variety of providers in that second column, both primary care and behavioral health, and many of the plans that operate in our state. I do think it's significant and important that employers in this initiative because of the growing importance and impact of mental health in the workplace. And as you heard from John a little while ago, one of the most compelling issues that has been raised by employers is the difficulty that their employees and their families face in getting mental health and substance use care. And you know, we hope that this initiative will change that and change it quickly. We spent the last year meeting both together and individually with each of the sectors. We've found differences, but also commonalities. And that's really important. We're in the middle of a healthcare crisis in this country that has huge mental health implications. We know the human cost of our failure to deliver quality and effective behavioral health care. And certainly the Milliman data that you all heard about a few minutes ago has demonstrated the significant problems that we're facing nationally and in the state of Maryland with respect to behavioral health care. And we also know that when we don't get it right on the behavioral health side, there's also huge cost in the overall healthcare system in terms of unnecessary spending when we fail to get it right. So it's really those overarching issues which, are what's putting the momentum behind this initiative. Next slide. So what I'm going to do quickly now is highlight a few more details about 3 of the 5 priorities of the path forward that John mentioned. And those 3 were actually decided by all of the sectors in our MidAtlantic project for action in this first year of this 5-year initiative. And the first is measurement-based care. And you'll see here, each one of these slides about the 3 priorities lays out our strategy for how we're tackling the problem. Who needs to, so Dan, can you go to, I'm sorry, the next slide? And basically, with each one of these, we're looking at who needs to be at the table, what is the agreement that we come to on the key issues and the barriers. Is there a common agreement on an approach we can work together on, and how are we going to measure those results? In the measurement-based care platform, some of the actions that we are looking at and working on are how can we increase the use of validated screening and outcome tools? How can we work together to address administrative barriers? We've certainly heard a lot about the degree to which issues surrounding our electronic medical records pose challenges, and also the adoption of measurement-based care standards that the accrediting agency, URAC, announced this summer. And we're actually quite proud that our project brought URAC leadership to our launch earlier this year, which resulted in dialogue with the national path forward around measurement-based care. And following up on that, this summer, URAC released measurement-based care standards, which are significantly focused on behavioral health. And so we will be working in our region to advance adoption of those standards. Next slide. And actually, Dan, I'd like to jump to slide 12, if you don't mind. Again, here, this just lays out our approach. In the collaborative care platform, as John mentioned, the Maryland Primary Care Program is an important partner in this effort, a central partner. We are working in the coming months to develop technical assistance and training for the primary care practices that are part of MDPCP, and much of that has come from the dialogue we have had with primary care community about what would be helpful to them in terms of addressing barriers. Electronic medical record challenges have come up. Ensuring reimbursement across all payers is another significant issue that we're working on, and as well as payment incentives to integrate behavioral health care. Next slide. Next slide. Again, that's what I just illustrated our approach. In terms of strategies with network adequacy, we are looking at ways to identify and address financial barriers. Key to that, of course, is ensuring that rates reflect supply and demand in the market. Certainly one of the things we have heard from payers this year is that they are making changes here, and several of the major payers in our state have increased rates for behavioral health because of the huge demand. We are also looking at streamlining authorization processes and expanding credentialing, expediting credentialing where there are access gaps, adopting standardized measures to assess network adequacy, and central here is the use of a new tool, the model data request form. Next slide. So this is a really important component of the overall network adequacy strategy. This is a validated tool. It's a tool that our employers are using now to assess adequacy of the networks for their employees. And the value of the MDRF is really essential in terms of providing data that up until now we have lacked, and you simply can't assess network adequacy or network access without a quantitative tool like this. And here you can see the 4 areas that the MDRF covers: out-of-network use, health and substance use versus medical surgical, reimbursement rates, denial rates, and the accuracy of network providers' directories. So with that,
Linda, let me jump back in here for 1 second. Regarding the model data request form, I think it's worthwhile to point out that this is something that purchasers have been interested in, that the purchasing community fields several instruments that evaluate health plan performance and vendor performance in a variety of ways. One of those ways, and the object of those evaluations is to see, in what ways are the vendors doing the kinds of things that we would anticipate them doing, and more perhaps, or less. This model data request form has been incorporated into that assessment that we use with behavioral health managed care type providers, such as health plans or carve out behavioral health managers. And we have incorporated that into that evaluation. It provides excellent quantitative data for us to understand how those plans are doing in that way. Not for a compliance reason, not for a gotcha sort of reason, but just to understand, where should efforts be directed, what kinds of things can purchasers be rewarding and assisting and supporting, and what kinds of changes should we be requesting. So this model data request form has implications beyond just being the form that it is, and purchasers appreciate that, not for fighting reasons, but for evaluation and understanding reasons. So thanks for letting me interrupt right there, Linda. I appreciate it.
We can't hear you, Ms. Rains. No.
It's all my fault.
Is your volume control down, or?
I think, Craig, I'm just having just some technical difficulties, but I think that was the last slide of that presentation.
Okay.
Okay, thank you very much. Given the difficulties that Ms. Green is having, I'm not sure that we're going to be able to ask her questions, but does anyone from the MIA have any questions of either Ms. Rains or Mr. Miller? Okay. Well, I want to thank you very much for the presentation. Very, very helpful to really see this in a very practical standpoint. I think that sometimes, that's sort of what the consumer in terms of the purchaser, of health plans is focused on, and that the drivers here are very much around both individuals who need care, but also those who need them to have care. And that includes, obviously, their employers who are buying and purchasing the healthcare financing tools. So thank you for that presentation. The next, we will hear from the Bowman Family Foundation, which is a private foundation whose primary mission is to improve the lives of people with mental illness. The foundation was a sponsor of Milliman's research and is a partner of the Path Forward. Speaking for the foundation today are Dr. Henry Harbin, the former CEO of Magellan Health, and Beth Ann Middlebrook of B. Middlebrook Consulting. Dr. Harbin, Ms. Middlebrook, thank you for joining us today. You two, if you can unmute yourselves, that would be helpful. And there you go.
Can you hear me okay?
Yes.
Okay. So we thank you for allowing us to present today. What we'd like to talk about is some of the tools and approaches that could be used to improve the assessment of NQTL compliance by plans and employers, for that matter. So I'm Henry Harvin. I'm a psychiatrist by background. I've been in the behavioral field longer than I care to think about, several decades. I did spend 10 years in the Department of Health and Mental Hygiene in the 80s. I was the director of the State Mental Health Authority for 3 of those years. I did also spend, relevant to this discussion, thanks, Dan, I was, for 15 years, I was an executive with and CEO of 2 national managed mental health care companies, so I'm very familiar with many of the state parity laws and some of the federal laws. But I left the Magellan. I've not been involved with any of the managed care companies since 2008 when the law passed, the parity law passed. However, Beth Ann Middlebrook, who is a healthcare lawyer and a parity expert, she and I both, as you see from this busy slide, have been very involved in the last 10 plus years trying to provide input to the regulators, both state and federal, advocacy groups on what are the best ways to monitor and measure compliance with the parity law, specifically around the NQTLs. I will give a trigger warning for this discussion. This is fairly technical language when we get into some of the details here, but as this is a technical discussion, we don't really have any choice. So it's also kind of boring, but except for those of us who live in this little world here of parity involvement. So, and I noticed there are probably some people on the phone that are well aware of these issues. So, but I have, and Beth Ann have been involved we are co-authors of this 6-step parity compliance guide. Parts of that have been incorporated into the Department of Labor self-compliance tool. We have provided input to a lot of some state regulators. We are actually right now a consultant with the Washington State Department of Insurance on their compliance measures and tools. She and I both worked with the Parity Implementation Coalition, which was for a number of years the coalition that provided a tremendous amount of detail on sub-regulatory guidance to the Department of Labor, IRS, et cetera. Recently, we had the pleasure of both of us being on the NAIC panel, national panel on NQTL compliance. So we sort of live this stuff and are very interested in seeing it done well. So you go to the next slide, Dan. And what I'm going to do is talk a little bit about what we've learned and some of the challenges and problems with complete NQTL compliance. And then Beth Ann is going to go over some of the more specific tools and that we think would be helpful to the MIA and others to do better market scans and evaluation. So I would say, first of all, that, over the last, 10, 12 years since the law passed, there has been increasingly pretty good compliance with the quantitative treatment limitations and the financial requirements. And so most of the plans that I'm aware of are doing a reasonably good job, with a few exceptions, in those areas. And I think part of that is that those areas are easier to measure and they're more transparent. So everybody can see whether or not you've got a financial requirement that is not in sync with parity, or you've got a 30-day limit, let's say, on inpatient care for behavioral and not for medical. But the real challenges are around these medical management protocols and various interventions to manage the benefit. And I will say, having been on both sides of the fence, both on the kind of advocacy, consumer protection side, but also on the plan side, is that you can manage the benefit with completely uncapped, no limits on quantitative limits at all, but you can manage a behavioral health benefit down to a very narrow margin just by using these non-quantitative measures. So what are some of the problems we have seen? And I base this on mine and Beth Ann's many discussions with plans, our help that we did with CHQI, which was developing a parity accreditation standard, our many long meetings that we've had with plan representatives of debating and trying to reach common ground on how to do this best, and our issuing some of these tools and seeing what responses there are. So So one of the key problems is, and this goes to the heart of what a state regulator would look at or receive if they are trying to do a more detailed deep dive on NQTLs. So one of the biggest problems is when a plan, when they're responding to how do they do an NQTL assessment, let's say for pre-certification or concurrent review, they list, many of them, the factors that lead to them to have applied or why they're applying an NQTL at all. But they are typically do not define that factor. So let's say if the plan says, well, we need to look at both medical and behavioral inpatient care, we need to do concurrent review because there's been a high cost escalation in that area over the last couple of years. The plans will often say, well, that's one of the reasons why we need to do this NQTL. And there's nothing wrong with applying a medical management protocol to both medical and behavioral as long as they're done in a comparable fashion. However, if you don't define what you mean by that factor, let's say of high cost escalation, you cannot really compare it. And what we find is these definitions are often missing. They don't give the quantitative evidentiary standard that defines what the factor is and don't provide any analysis of the medical versus mental health benefit. So when that's not provided, you really have nothing to assess from a regulator point of view. You have no way to know, is this comparable? Is it applied more stringently or not? The second major category is in this analysis is a part of the guidance from the Department of Labor, IRS, et cetera, is that when you're looking at whether or not you are applying an NQTL, let's pick pre-certification again as an example, are you implementing it in the way that you designed it? So if you say, well, we're going to do acute hospital in pre-certification for both medical and behavioral, and we've defined why we're doing it clearly, then the question is, are you actually implementing it in a comparative way? These are all in the guidance given by the Department of Labor over the past decade. So we find that it is rare, if ever, that the in-operation phase of when an NQTL like this is applied is tested. And what the guidance requires is, well, okay, let's say you are doing pre-certification, but when you do it on medical, you give on average of 5 days of care when you authorize it, and you give only 2 days of care for behavioral. The plans need to be able to audit that and prevent that data that they audited to show that, in fact, they are implementing this in a comparative way. Another common problem is on reimbursement rates, and that's partly why the Bowman Family Foundation has developed quantitative measures, which you talked about with the MDRF, which are used by employers. You'll hear more from that about Beth Ann, but the issue is here, you can't really, there are many reimbursement levels that can't be compared, but they're on a quantitative basis, but there are some. And we find that it's rare that data and the mechanisms for that will be disclosed when a plan is saying what how their reimbursement rates are comparable. The last category of this is one that is quite challenging, that the Department of Labor laid out in 2016 a very detailed, frequently asked question about what needs to be disclosed if a consumer or provider on behalf of a consumer asks for information about why a particular medical management protocol was applied. And they laid out what has to be disclosed to that consumer or provider. And as yet, in my 10, 12 years of looking at this, I've yet to see a plan provide a disclosure request that's consistent with that FAQ. So, Dan, would you go to the next slide? So in conjunction with some of the lack of full analytic responses on plans' part, this is what we've found that is missing sometimes from the regulator side. So, and based on these more common challenges, a lot of times in our view, and I haven't seen what every regulator does, but I have some knowledge of this from our time from talking both to the federal folks a lot, is they may not ask for these specific methodologies to be done as a part of their market scan or their assessment. So if you don't ask for it, you're not going to get it in a clear fashion. So asking for these, for instance, these factors to be defined by the evidentiary standard or the operational analyses to be done, you're not going to get them. So this is a kind of a heads up, I think, to the regulators if they want to get more detail in the areas where there's not been full compliance or disclosure. Another one is this gets to this quantitative definitions. I have found that a number of regulators are asking for, example, are there differences in out-of-network rates? Are there differences in reimbursement rates? But they don't define the methodology or what they mean by that. And the employers, and they're using the MDRF that they're using as John Miller laid out. We have found this in their responses. That's why they adopted the model data request form as just a way to have a consistent definition. But if you ask a broad qualitative thing like, are there any differences in denial rates between medical and behavioral, I can pretty much be confident you're not going to get a very clear answer to that because you haven't laid out, meaning you, the regulator, how to define it and what parameters. So I think that's kind of the major things that I think that I wanted to say about some of the problems. So now Beth Ann is going to share some of the more details here about how what are some tools that you could use as a regulator or a plan could use themselves. Beth Ann?
Thank you, Henry. Pleasure to be here. So the next slide addresses the steps that are required for NQTL compliance analysis. And these steps are primarily taken out of the recently published 2020 MAPEA self-compliance tool. And that compliance tool was just updated officially within the past week or so. And so that's where this information comes from. Henry mentioned the 6-step parity compliance guide for NQTLs that he and I were co-authors of along with other experts. And the DOL-HHS has adopted a similar multi-step parity compliance guide in this self-compliance tool. And so step 1 is to identify the NQTL, including all services that the NQTL applies to in each benefit classification. The second step is identifying the factors that are considered by the plan in designing each NQTL. The third step is defining each factor according to the source and any evidentiary standard that defines the factor, including quantitative measures that form the basis for the application of the NQTL. And that's what Henry has been talking about. And those are quantitative measures that the DOL-HHS has provided explicit examples of that we'll get to in a moment, describing when the application of the NQTL gets triggered. And that's very important because these steps build upon one another. The next step is the conducting of comparative analyses between the behavioral and the med-surg benefits for each NQTL, both as written and in operation. So this is sort of a loaded step, and it's in order to demonstrate that the NQTL was designed comparably and no more stringently, and that it also is applied, not only in writing, but applied in operation in a way that is comparable and no more stringent. And this analysis also necessarily includes outcomes data, such as what Henry was speaking about, such as denial rates and reimbursement rates and out-of-network use. And as the federal regulators have made clear, disparities in this type of outcomes data, while it's not dispositive in terms of determining compliance, these disparities are important in that they indicate a warning sign or a red flag, indicating that further investigation into comparability and stringency in the application of the NQTL is warranted. So the significance here is that even if, at first blush, the processes and methodologies and other factors that are utilized appear to be comparable, if there is disparities in outcomes data, then it's a warning sign. And those processes and methodologies need to be further investigated because apparently something is not right. And equitable application in operation of the NQTL is not being seen. Next slide, please. So in the 2020 self-compliance tool, it fleshes out in more detail what, with respect to quantitative measures defining factors, what the parity final rules in example 2 under the NQTL spoke of way back when the final rules were published. And if you look at example 2 under the NQTL rule, the regulators mention that, for example, if the quantitative evidentiary standard that defined a factor, for example, a plan conducting concurrent review, the plan had to disclose there when it used high levels of variation in length of stay as a factor. The plan disclosed that as measured by a coefficient of variation exceeding 0.8. I mean, that's an example. So the regulators were assuming that to the extent that a factor could be defined by a quantitative measure, that quantitative measure defining that factor needed to be provided. So branching off of that and jumping off of that, the self-compliance tool further fleshes that out. And the way the compliance tool sort of characterizes it is by saying the plans must identify any threshold at which each factor will implicate the NQTL. So examples of how factors identify based upon evidentiary standards that include quantitative measures that are defined includes these thresholds. So, for example, excessive utilization, that can be defined and is often could be defined as 2 standard deviations above average utilization per episode of care. And these examples are so important because it shows in a concrete way how this is necessarily done and how important it is to disclose this type of information. So recent medical cost escalation, that could be defined as internal claims data showing that costs increased 10% or more per year for 2 years. Next slide, please, Dan. Further examples are lack of adherence to quality standards. That can be considered as a factor when deviation from generally accepted national quality standards occur more than 30% of the time. Or you've got high level of variation length of stay. That could be defined as, showing 25% of patients stay longer than the medium length of stay for a particular setting, acute hospital episodes of care. Or high variability in cost per episode. That could be defined as 2 standard deviations higher in total cost than the average cost per episode 20% of the time in a 12-month period. Or a factor of lack of clinical efficacy. That could be defined as more than 50% of outpatient episodes of care for diseases are not based on evidence-based interventions in a 12-month sample of claims data. And although this seems awfully technical and it gets a little long-winded, these examples are so important. And once this type of quantitative measures are disclosed, then that makes the following steps in terms of comparability and stringency in analysis between behavioral and med-surg possible. Next slide, please, Dan. The 2020 self-compliance tool also added some very important examples of warning signs with respect to reimbursement rates that may be indicative of non-compliance and would warrant further review. As will be shown in the next slide, typically outcomes data is significant in terms of a compliant and complete analysis of operational compliance. But in addition to operational compliance context, in the reimbursement rates context, this could be as written. This type of data plays a significant role and is necessary in terms of conducting an NQTL compliance analysis when it comes to reimbursement rates. So the tool states that inequitable reimbursement rates established via a comparison to Medicare, for example. So if you have a plan or issuer paying at or near Medicare reimbursement for behavioral health, while paying much more than Medicare for Med-Surg, that is a warning sign. And for further details, there's an Appendix 2 that can be referred to. Another outcomes-based warning sign is if there are lesser reimbursement rates for behavioral health physicians for the same E&M codes, for example. So a plan or an issuer reimburses psychiatrists less than medical surgical physicians for the same E&M codes. That's a huge red flag. The third is not necessarily an outcomes data approach, but is a very interesting consideration when a plan or issuer generally considers market dynamics, and I think Henry referred to, for example, market trends or market studies, supply and demand, and geographic location. For example, that's considered on the Med-Surg side, but on the behavioral health side only considers certain quality measures and treatment outcomes. Then that is certainly problematic in terms of NQTL compliance. Next slide, Dan. Thank you. So turning now to examples of outcomes data necessary for the operational analysis for NQTLs. The self-compliance tool expressly notes and includes compliance tips, showing that this type of claims-based outcomes data is necessarily part of operational compliance analysis. So determine the average denial rates and appeal overturn rates for concurrent review. Assess the parity between those rates. Or for the period of coverage under review, the plans and issuers should be prepared to provide a record of all claims on both sides, both Med-Surg and behavioral health, submitted and the number of those denied within each classification of benefits. And these are just examples, denial rates, but other outcomes measures are equally valuable and necessary for a compliant and complete NQTL compliance analysis. Now, certainly, as others have said, while outcomes are not determinative, rates of denials rather, and other outcome measures need to be reviewed as a warning sign or an indicator of potential operational parity noncompliance. Next slide, please. So there are additional resources that we wanted to point out that help plans in complying with NQTL analyses. And one of these tools is best practice examples with regulatory guidance embedded. Now, and here's a link to that. And these best practice examples were developed with input from a variety of national experts and on how to conduct a complete and compliant NQTL analysis. And what's really important about these examples is that they provide a concrete mechanism that actually demonstrates how this is done and how it works. And it becomes much clearer when you follow the flow of these narrative examples, how a complete and compliant analysis is conducted. And regulatory and guidance is embedded in these examples so that whether it's an employer or a plan or a regulator or a provider who's looking at these NQTL or a consumer who's looking at these NQTL best practice examples can refer to the regulatory guidance that supports each aspect and each element of these examples. There's also a Milliman white paper that's entitled Non-Quantitative Treatment Limitation Analyses to Assess and MAPEA Compliance. And Milliman did a good job in this white paper in providing guidance through the 6 steps, explaining the 6-step process, which actually sort of contributed to the multi-step process that the regulators have adopted in the self-compliance tool. And Milliman also included quantitative claim data-driven comparability analysis to ascertain disparities and fleshes that aspect of NQTL compliance out. So that's a valuable tool. Next slide, please, Dan. So we wanted to dedicate a full slide to the Model Data Definitions and Methodology Form. The MDDM is what it's called. And the MDDM actually utilized the MDRF that's been talked about in these presentations as a source document for a detailed, specific instructions and details that are to be followed in order to elicit consistent and reliable responses from plans on quantitative measures for determining outcomes that are salient when looking at NQTL compliance. And so the MDDM requests data, again, that measures disparities in out-of-network use, disparities in reimbursement rates, in denial rates, and in network provider accuracy of their directories and participation. And the key here, too, is to look at these data outcomes with an eye toward how disparate outcomes raise, here in this context, raise a red flag or a warning sign that perhaps whatever the methodologies and processes that are being followed are, and to the extent they may appear at first blush as being compliant, that there's actually an indication that there may be parity non-compliance and that an additional investigation is warranted. And at this point in time, Washington State, their Office of Insurance Commissioner, has utilized the MDDM as part of its second market stand with respect to requesting quantitative measurements data and outcomes data that demonstrates whether the plan is compliant or not. And it's helping a great deal in terms of providing Washington with a platform to request consistent or to elicit consistent, reliable data to help it do its audit compliance audit. Henry, did you have anything more to add? Can you unmute yourself, Henry?
So I don't know. How about now? Can you hear me?
Yes, we can.
Okay. So a couple comments. One is that because some plans have stated, well, they really haven't gotten this kind of specific guidance from the Department of Labor until recently, but I would point out that the self-compliance tool was actually issued in 2018 as a final set of guidance, and it was based on the Cures Act, for those who remember that, in 2016. And in the Cures Act, which passed, overwhelmingly bipartisan support, there were a couple of pages in there, guiding Department of Labor, IRS, et cetera, to be more specific in their guidance. And so they issued the self-compliance tool. It's been added to with additional examples, which has been helpful, but it's been out there, and that compliance tool, when it came out, had built on prior FAQs and other guidance given for really since 2012 by the Department of Labor. So I think it's the examples are here, the steps are here, and I think it's important to know they've been out here for a while. And I know that a number of plans are trying to do a more detailed job in these NQTL analyses, which is great. I would, but the examples that I gave at the beginning of problem areas, when you go over the list of specific quantitative measures that Beth Ann did in the examples, if all you do when you provide a regulator a NQTL analysis, you say, well, here's the factor I defined, high cost escalation as 10% a year for 2 years, and then you don't provide any analysis of whether or not the service categories in medical met that standard, and the same as behavioral, you really have nothing to measure. You have no way to judge. And what plans often tell us, well, we had a committee that looked at that. You know, yeah, we did a test, but we're not sharing that test, or we're not sharing the results. That is, when you add that to disparate outcomes, you really have two problems. You have disparate outcomes showing you don't have the same access, which is ultimately the goal of parity, right? And you don't have a complete analysis of the NQTL. So you've got really two problems on your hand. So anyway, I would just say that while John and Linda talked about how the employers are using the MDRF, the employers, when they're using this quantitative analysis, they are not using this as a parity compliance tool. It's not the path forward, and the employers are not looking at themselves as parity compliance monitors. They're really asking, this is a private sector to private sector request to get more accurate data on what are the access issues and what can we do about it between these two parties. So what we're talking about in representing the Bowman Family Foundation and ourselves, Beth Ann and I, about these specific applications in a regulatory fashion is a different approach and some consistent. The final thing I'd like to say is we do hear from plans that they're having to respond to 50 different state regulators. They get asked all kinds of different questions, all kinds of different analyses. And I would hope there would be some convergence here, particularly when it gets down to specific quantitative analyses or requests or detailed applications, trying to come together for the sake of the plans as well as for the regulators to get some consistency in approach so that a plan itself could do these calculations once and then they'd be good for everybody. So both the employers as well as the regulators. So anyway, I don't have anything else to add. So thank you, Commissioner Bahrain, and for allowing us to present this kind of detail.
Thank you very much for that very, very informative presentation. Is there anyone from the MIA that has any questions? Give me 1 second here. Trying to check out what's in the chat room. give me 1 second to look at because my mouse isn't working. There we go. All right. And look, there are a couple of chat questions. Just want to make sure before we finish up. So we do have a question in the chat room that I am going to read, which I think is directed at the Bowman Family Foundation. Can you, and if this is too technical, we can take this offline and give you the opportunity to provide
I can, Commissioner Bahrain, I read it. I could give a response if you want.
Yeah, and if you're able to give a verbal response, that's great. If it's something you need to take offline and do in writing, and then we'll post it to our site or get it to Mr. Silcott, that's great.
We can do that.
Happy.
Basically, this is a question about the Section 4 of the Model Data Request Form or the MDDM, either one. It's an assessment of using claims data of how active is the network for psychiatrists. And it basically does a measure of the last 6 months of data, claims data from a plan. This is if an employer asks for this data or a regulator. And it says if you've got, 500 psychiatrists in your directory, and how many of those psychiatrists billed you for a unique patient in the last 6 months? Was it 0? Was it 10? And then how many billed for 4 or more? Or 4 or less. So it's really a measure of the activity of the network of psychiatrists. It is not technically a parity comparison because it doesn't ask for medical data. This was, I think we all know that it's very challenging to measure network access in a an efficient way on a lifetime basis. It's a challenge for everybody, the NCQA, a plan itself. This is a way to get a claims data as to how active the network. So there is no national standard here that says if you have 100,000, lives in a jurisdiction, you should have 30% of your or 80% of your psychiatrists billing you. But it gives you a snapshot of if you've got a really low participation rate. And we have seen this with some of the work that the employers did, where they found as much as 20 to 80% of the psychiatrists were seeing no patients in 6 months or less than 4. So it's not technically a parity tool, but it's an attempt to try to focus some level of quantitative analysis on a key issue, which is how active is your network. Now, there's nothing to prevent a regulator from adding comparisons. So let's say you might want to measure oncologists and, cardiologists compared to psychiatrists, and you may want to use other disciplines, psychologists and social workers. But again, this, from the employer point of view, where this was initially promulgated or use of this, was the challenge of getting a psychiatrist in network is probably, even though it is often hard to get a psychologist or social worker or an inpatient facility. But so anyway, that answers part of the question. We could take it offline with David Shilcoat later on some of the other questions. But that's a common thing we get asked, like, what does this really mean and how are you using it? So,
Dr. Harbin, thank you very much for that. One of the other issues that has come up in the chat room and then separately, and this is really more for Milliman, but others may want to comment on this as well, and that is the data and the age of the data. And I guess one of the concerns that folks have is as we look at particularly comparisons of Maryland, what is the age of the data we're looking at? And have there been changes? And are there, I guess, has additional data been collected? And, what is the plan with regard to updating these metrics and this analysis based on more updated data, particularly given the changes in Maryland law that have occurred since some of this data was collected and analyzed? Does anyone have a comment on that from the panel, any of the panels?
This is Stoddard from Milliman. I can comment on the age of the data. So the report that we published in fall 2019 included claims data through the end of 2017. And that was a 2-year update. So at Milliman, we generally have somewhat of a lag before we have data available for sort of general research use. So it can be, a year and a half or more after the close of a calendar year before we have complete data that's sort of been through all our processes to make it available for research. I can't speak right now to specific update plans, but other than to say that it continues to be an area of interest to us.
I think what I would add to that, Stoddard and Commissioner Brain, is that the Milliman data or any big database like that is usually 1 or 2 years old. However, this is part of why the employers are asking for this, because they're talking to their customers, right, or self-insured employer, and they can get more recent data if they ask for it. And in fact, some of the evaluate measures they've done regionally have gotten some of this data more recently. Now, they don't publish that data identified, but some of the data de-identified shows some of the same persistent trends. But one of the values of the employers asking for it, it's their data, really, if you think about it. When they're asking their TPA to give them this claims data aggregated in a certain way, it's their data. Even though some of what they ask for is broader, multi-employer data, but it is more recent and they can get that data. So, for instance, if the state of Maryland, the employee benefits director, were to ask for the model data request form, they would get probably last year's claim data, whatever the latest runoff. So this is the value of, the employers focusing on really the outcomes. How do we improve access? How do we improve better care and collaborative care? And I would point out what John and Linda said. Many of the recommendations of the path forward are unrelated to parity, but we think they're essential, like better accountability with measure-based care, improving care in primary care. These are not parity issues, but they're essential to improving access to quality care. So, but anyway, that would give you a little bit of a response about the recency of the data.
No, I appreciate that very much. And then that's helpful to know, and we will be following up with you with regard to those data sources. Delegate Colson has, I believe, Craig, you've been able to add her as a participant?
Yes, she is now a panelist.
That's great. So, Delegate, welcome. We're so glad that you're participating. I know you have some questions for the Bowman Family Foundation, so we're happy to have you ask those questions and make any other comments that you like.
Thank you very much, Commissioner. You can hear me, right?
We can.
Okay, excellent. And I want to thank you all for allowing me to participate or inviting me to participate and to ask some questions. And I want to thank all the panelists for the work that you're doing. It's really important work, particularly in this time. I mean, you know, we always, those of us who believed in the need for mental health services and access to it and affordability forever are now even more sure of what we were asking for in this pandemic, because we see it now becoming one of the major negative consequences of the pandemic is the increase in need for mental health services. So that's, I mean, just to lay the context that I understand the need for this. So I have a couple of questions. One about the self-compliance document, and in defining the evidentiary standards. Well, let me back up just a second. I agree completely with Dr. Harbin around the need for federal guidance. I mean, you know, I think about our own, you know, payers here in Maryland having to deal with 50 states, or many of them have to deal with 50 states. If we all have different evidentiary standards, I think that is, as someone who cares about insurance costs, I can only see that just skyrocketing costs, because there's a lot involved, as you know, evidenced on the slides that we're seeing. But what I wanted to know about the self-compliance document is those standards. It looks like those are developed uniquely by the payer in this self-compliance kind of mode. Am I hearing that correctly? That's number one. And number two is we can gather all that data. We can require, you know, payers to gather that data, but who does the analysis of that data? I mean, is that the secondary part? I mean, I think Dr. Harbin sort of addressed this a bit, but I wasn't sure that it got all the way to, I'm not sure who's actually saying, okay, this is what we looked at in terms of reimbursement rates. What does it mean? And what do we have to do beyond that? Does that totally fall to the responsibility of the payer, or is this something that needs to be looked at from a policy standpoint?
Well, I'll respond first, and I bet Beth Ann would also probably give me a better answer. So I don't think the payers were the main determinants of the federal guidance. I think they hear from everybody, right? They get a lot of input from payers, from advocates, from providers, et cetera. So the self-compliance tool, I thought, was pretty good, and it's been improving each year. One of the advantages of using a consistent measurement set of definitions, like the MDDM that Beth Ann mentioned that Washington State is using, is, and the employers are using the same definitions, is you reduce the load on plans to have to provide this. So it's also set up that the data is asked to be presented in a consistent format. So the analysis of this gets a lot easier. You get the answers from the plan in the format you've requested them. So you get, like for reimbursement, there's a very specific chart you fill out, like based on what you provided, what were the conclusions, and you end up with a disparities report or non-disparities. It says, well, we pay primary care docs for these two particular codes X amount compared to Medicare, and we pay psychiatrists and others Y amount. What's the difference? So it reduces if there's a consistent use of a consistent definitional form methodology, it reduces the workload on plans, and it also reduces the workload on a regulator because you've got that data portrayed in the same fashion.
I have been trying to reach to you from the last meeting.
Sorry for the background noise here.
Notifications
and
might be
so, and the other question I had is how often
can I go ahead and add to Henry's response?
Yes, please.
Okay. So when you're asking about the evidentiary standards that define factors, when those evidentiary standards involve quantitative measures, yes, you're correct. So the plan does develop that, and the plan, you are correct. The plan comes up with, if the plan is defining, a high variation in length of stay, for example, as 25% of patients staying longer, or whatever the case may be, that is up to the plan to define. And so long as there is comparability and no more stringency, as applied, both in writing and in operation, that's fine. And because that's the key, as long as it's comparable between behavioral and med-surg. But those quantitative measures are, in fact, developed by the plans. And then it is up to the plan when the plan is providing its NQTL compliance analysis to provide a regulator with its comparability analysis. Yes, it takes those evidentiary standards, and the plan needs to explain the comparability analysis that it conducted in order to determine that not only those evidentiary standards themselves, but the way those evidentiary standards are applied to the med-surg and the behavioral health benefit is comparable and no more stringent. So that comparability analysis would need to show that all the services in each benefit classification that meets that evidentiary standard or that threshold that triggered the application of the NQTL are in fact subjected to that NQTL and are done so equitably. So that type of comparability analysis is not a burden that the regulator needs to take on. That is for the plan to do. And then as part of the comparability analysis, that is where outcomes data comes in. And when looking at outcomes data in terms of reimbursement rates, and then also in terms of operational compliance, as we've talked about, there could be compliance in writing, but as implemented operationally, there could very well be issues so that the implementation of the NQTL is not in accordance with how the NQTL was actually designed in writing. And when it comes to operational compliance, that's where this outcomes data comes in order to demonstrate whether there is or perhaps a warning sign that there is not operational compliance. And so how do you get consistent, reliable outcomes data? That's when the MDDM comes into play
Let me see if I can add one thing here, because maybe I misunderstood what the question was. That the parity law was not designed to say you can't use medical management techniques in behavioral health. So health plans are free to do whatever medical management, setting rates as an NQTL, doing experimental, non-experimental, measuring for quality. These all can be NQTLs. All the parity law says, well, if you have one, you need to show you're not using that particular NQTL or medical management protocol in a non-comparative, more stringent manner. So I would say, though, one of the concerns I have is, the plans, in at least some of the responses I've seen in their response to the self-compliance tool in 2018, 2019, have pushed back on these multi-step processes. Not all of them, but some of them. And I really feel their workload would be a lot less if they would just do these complete analyses for their NQTLs so they can disclose them the same to everybody. I mean, I guess maybe I'm probably in a minority on this view, but I don't think it's that complicated. I think you can do this, you can do these comparisons, and if you're roughly doing them in the same fashion, then fine, you have no problem. You can do pre-cert, you can do setting rates, you can do whatever, as long as you're doing a comparable manner.
Well, I guess one of the things am concerned about, is consistency. And what I'm hearing is if standards are different among payers, then the analysis ultimately has to be the same, even though their standards might be different. You say this, Middlebrook, but so I guess, and maybe I'm shooting for the myth that isn't there. I'd like to make it as uncomplicated as possible. I want this information, but I want to make it as uncomplicated as possible so that we can see quickly and easily what kinds of changes need to be made and how we can improve our systems. So, I think that's, from my context, I'm going to be considering that as we think about how to develop the regulations.
Well, of course, that makes a lot of sense. I will say, though, that notwithstanding that plans, certainly internally are able to come up with their own definitions for factors, the evidentiary standards, or also known as the thresholds that may trigger the application of NQTL. Yes, they're different from plan to plan, but that doesn't necessarily complicate things because, again, as Henry just stated, those standards, whatever they may be, they need to be disclosed. And then in order for a regulator or anyone to be able to assess the comparability of those standards in terms of as written and as applied between the behavioral and the medical surgical. But without the disclosure of those standards, there's no way to conduct a comparability analysis.
Yeah, I would add to that. I know it sounds complicated, but if a plan were to follow the self-compliance tool on any NQTL, identify the evidentiary standards, say, hey, it's whatever it is, rapid costs, quality measures. Here's the analysis we did to show medical and behavioral were treated the same. We did a couple of audits on the in-operation to know, well, we only review every 5 days. We do that consistently. For medical, it could be different evidentiary standards, but they show that it's comparable how they did it and the way they did it.
That's right.
You could look at that in 5 minutes and say, this is a consistently done, and then you add some quantitative disparate data on that would say, well, you had a huge disparity, but you were completely compliant with parity. You still have a problem, but it may not be a parity problem, which is where the path forward comes in. Their issue is, we know we have an access problem to very effective care. We're working on that in multiple ways. Parity is just one part of that.
Mm-hmm. Okay.
The best practice examples with regulatory guidance embedded are really very, very useful because, when you see how the examples lay out in a concrete way, it becomes an aha moment because a lot of this can sound abstract, absent reviewing, concrete best practice examples.
Thank you. Thank you very much.
Yeah, Washington State did go ahead and include the best practice examples in its market scan and highly encouraged plans to please look at those examples to guide them in responding.
Thank you. And thank you, Commissioner, for letting me ask the questions.
Absolutely. Thank you. And if you have other questions as we go, please just let us know. Okay. All right. So at this time, we are going to hear from the individuals and organizations who requested the opportunity to speak. I think there are 7. So I'm going to ask each speaker to try to keep your remarks to just 3 or 4 minutes so that we can hear from everybody. And please keep in mind that this is the first hearing. It's not the last hearing. This will be, as I've said, an open and a transparent process with many opportunities to be heard. In addition, we will continue, as we have, to solicit written comments and suggestions. So I'm going to go through the folks that have already signed up. When I call on you, please state your name and your affiliation, and let us know whether you have submitted materials for posting on our website. Submissions that we've received so far have been or will very shortly be available on the MIA's website. In addition, while our scheduled speakers are talking, if you would like to be heard but you have not signed up, please identify your name and your affiliation in the chat room or email Mr. I. If we have time, and I'm not sure we will, but if we have time, we will call on people and give them the opportunity to be heard. So with that, let us start with Ms. Geddes, who is the Director of Public Policy for the Maryland Coalition of Families.
Hello, good morning. Can you hear me?
Yes.
Yes, all right. Good morning, and thank you for this opportunity to speak. My name is Ann Geddes. I'm the Director of Public Policy for the Maryland Coalition of Families. MCF provides family peer support and navigation services to caregivers of a child or adolescent with behavioral health needs and to any loved one caring for a person with a substance use or problem gambling issue. The main request of the families that come to us for help is with accessing appropriate treatment for their loved one. As our staff try to help families access treatment, they frequently encounter families that have been struggling to find an in-network provider within the required time and distance metrics. This can be especially difficult for families seeking a provider that specializes in working with children and adolescents. Families frequently end up seeking services out of network. We hear of families being on the phone for hours and sometimes for days, looking for an appropriate in-network provider that is first, actually still within the network, and second, is serving new patients, and third, can be seen within a reasonable time and distance. These families often end up going out of network, and many do not know that if they seek approval from their insurer, the insurer must cover at least a portion of the out-of-network costs. The situation is especially critical for families of adolescents with significant substance use problems. Currently, there are no providers of substance use residential treatment services for adolescents in the entire state of Maryland. Families must go out of state and frequently go out of network. Not many years ago, there were 4 such programs in Maryland. I interviewed 3, asking them why they ended up shuttering their adolescent programs. Inadequate rates were given as a key reason by all providers, along with insurers that would only approve a handful of days of treatment, making it impossible for them to sustain their programs. You have written testimony from one mother who couldn't be here this morning, who struggled to find adolescent residential substance use treatment for her son. When she finally did locate a provider who was out of state, the insurer would only approve a few days of treatment at a time, and then after 2 weeks, they abruptly denied any additional days because their clinician had determined that no more days of treatment were needed. This directly contradicted the evaluation of the treatment center's treating clinician. Nonetheless, the insurer's clinician had the final say. We also know of families that have turned their child into law enforcement or pressed charges against the child in the hopes that by entering the juvenile justice system, the child could get the intensive substance use treatment that they desperately needed. It goes without saying that this is a drastic solution to a tragic problem. Inadequate networks, inadequate reimbursement rates, and ridiculously few allowable days of treatment are all a violation of mental health and substance use parity regulations. We ask that these insurance carriers be held accountable. Thank you. That's all.
Sorry, I was trying to find my own. So thank you very, very much for those comments. Does anyone from the MIA have any questions, Ms. Geddes? Well, thank you very much. I believe that you did provide written testimony.
Yes, I did provide written testimony. Yes, I did.
If it hasn't already been posted to the website, it will be shortly posted to the website.
Right. Thank you very much.
I would like to now introduce Dr. Peter D'Souza, who is the CEO of Hope House Treatment Center. So, Mr. D'Souza.
Thank you for allowing me to speak. My name is Peter D'Souza. I am the CEO of Addictions Recovery, Inc. Can you hear me?
Yes, we can hear you.
I'm the CEO of a private nonprofit organization called Addictions Recovery, Inc., doing business as Hope House Treatment Centers. We are one of the largest medical inpatient programs dealing with mental health as well as addictions. Most of the insurance companies that we deal with have their own ranking systems for service providers. We are consistently rated in their highest tier, like gold or platinum levels. Yet, when it comes to negotiating new rates, they are consistently deliberate in slowing the procedure. We are right now negotiating with a private insurance company from October of 2019 and still have not been successful in getting the rates established. So they string us along as they pay us the old rate. Also, as Dr. Henry Harbin and Beth Middlebrook talked about the disparities in reimbursement, I recently came to know that another organization very similar to ours was being reimbursed at a much higher rate than we were. And it really is, from my perspective, I don't know whether the insurance companies tell everybody not to disclose the rate to other service providers. But when I came to know that they were paying somebody much higher than they were reimbursing us, I questioned them, and now they are saying to me, "Oh, okay, we're checking. We're going to see what is happening." And it really becomes an issue when you provide excellence in services, and yet when it comes to the reimbursement rate, they try to hit you at the lowest rate possible. Thank you for that.
Thank you very much for your comments. I do appreciate you taking the time to share that perspective and that information with us. Does anyone from the MIA have any questions? Well, thank you very much. We'll next hear from Ellen Weber, who is the Vice President for Health Initiatives at the Legal Action Center.
Thank you very much, Commissioner Bahrain, and thank you for the opportunity to submit Legal Action Center's recommendations on the non-quantitative treatment limitations that the Maryland Insurance Administration should require compliance reporting on. I have submitted written comments, and I'm just going to briefly summarize them. As I mentioned, I'm Ellen Weber. I'm the Vice President for Health Initiatives at the Center. The Center is a law and policy organization that fights discrimination, builds health equity, and restores opportunity for people with substance use disorders, criminal records, and HIV or AIDS. The Center leads the Maryland Parity Coalition, which has worked to achieve effective enforcement of the Parity Act in Maryland's private and public insurance markets. And we led the advocacy efforts to secure passage of HB 455 in this last session. We really do appreciate the MIA bringing in experts to discuss several of the NQTLs that we think are most critical to ensuring that Marylanders have access to mental health and substance use disorder services that they need and that they're paying for. In implementing the reporting requirements under 15-144, the Center urges the Maryland Insurance Administration to require reporting on all NQTLs that a plan imposes on substance use disorder or mental health benefits, and not just those identified in the NAIC pool. We have 4 reasons for that. The first reason is that we think it's important and necessary, in fact, to comply with the statutory language in 15-144, which incorporates the federal law definition and illustrative examples of NQTLs. Second, it's important to ensure consistency with federal compliance guidance issued by the Department of Labor and Health and Human Services. Third, it's important to ensure consistency with state reporting requirements in other states. And finally, it is very important for the MIA to continue to build on its already strong enforcement of NQTL provisions through market conduct surveys and to build on those investigatory findings of your market surveys and what other states are identifying in their parity investigations. Any effort to limit NQTL reporting to those elements set out in the NAIC market tool would undermine the MIA's efforts to ensure equitable network adequacy, reimbursement practices, and scope of services, among other design features. These are the very NQTLs, Commissioner Bahrain, that you noted are the very practical implications of restrictive carrier practices. And it's what we've already heard about as being the basis on which individuals get access to mental health or substance use care. But to limit it to the NAIC tool would be to actually ignore the very practices that the MIA's market investigations and network adequacy reporting have identified as the most problematic for Marylanders. Mr. Davenport's testimony clearly identified these disparities, and Mr. Miller's examples of an employee who can't get access to in-network services and thus is unlikely able to get affordable care is what we see all too often and what the MIA has already found to be a problem across the carriers in Maryland. And in addition, only limited to what's in the NIAC tool would forgo the most effective strategy to identify and remove these barriers to care. Without full reporting on all NQTLs, it would put the burden back on consumers who have a limited ability to identify violations in many of these areas and have no access to the information required to determine a violation. Dr. Harbin noted that carriers are not disclosing this information that's required under federal law, and that regulators on the federal level and on the state level have identified are essential. So if you can bear with me for a few minutes, I'd like just to go through these items, one by one. First, with regard to the statutory provision, what the statute as enacted requires is that a report has to be filed that covers each parity classification. And I'm quoting here, with identification of non-quantitative treatment limitations that are applied to mental health benefits and substance use disorder benefits and medical and surgical benefits. The statute then defines NQTLs by reference to the federal regulations. We all know that the federal regulations set out a non-exhaustive list of plan design features that are considered to be NQTLs. That list and the federal rules preamble includes design features that aren't included in the NAIC document. That includes network adequacy, reimbursement rate setting, scope of services, and many others that are set out in my testimony. So selecting a subset of NQTLs would not comply with the statute as it's written. So to the extent that the MIA uses the NAIC tool as a starting point, we believe that the MIA must revise it to include all NQTLs as provided in Section 2 of the bill. You're given the direct authority, as you identified at the beginning of the hearing, to revise that tool in order to comply with the statute. The statute clearly identifies that NQTLs that are applied to mental health benefits and substance use benefits have to be reported on, and it takes the precise definition of NQTLs from the federal law. The failure to do that amendment, that modification of the tool, will inadvertently give carriers the ability to adopt discriminatory practices in critical defined features such as reimbursement rate setting, network adequacy, and the scope of benefit coverage. As I mentioned before, it will be nearly impossible to uncover that through other enforcement mechanisms. And I want to give you one example of what the MIA has just recently done to show why that kind of reporting in the reimbursement rate context is essential. You've issued an order against United Healthcare. And what that order found was that United Healthcare was setting reimbursement rates for out-of-network services in their HMO plans in a discriminatory fashion. It was using a standard that was not comparable for mental health and substance use disorder benefits, and it was actually reducing down the reimbursement rate below what the state statute even allowed for, and also in a non-comparable way to medical surgical services. Now, There is no way that a consumer would be able to have identified that violation. In no way, shape, or form. It actually took the MIA 19 months to get to the bottom of the carrier's practice. Consumers and providers will never be able to do that. So that's a perfect example why you have to include this reimbursement practice if we're trying to get at the source of what bottom line determines whether somebody's going to get access to care or not. And that's not included in the NAIC tool. Very quickly on the other items. The second reason, as we've already heard in great detail today, the Department of Labor's self-compliance tool makes clear that carriers have an obligation to comply with the Parity Act on all NQTLs. As we've also heard, they just reissued their self-compliance tool in November, and it reinforces that reimbursement rate setting practices to address network shortages, coverage of intermediate levels of care and other NQTLs, not identified in the NAIC tool, I might mention, are subject to review and must be available in the context of the DOL audit. The MIA has found violations again in these very same areas through their market conduct surveys. The third reason, we think that the Maryland Insurance Administration should adopt practices that are consistent with other state departments of insurance reporting requirements. Delegate Cullison identified that as a concern that she has. The charts that we've attached to our testimony that demonstrate that 11 states, in addition to Maryland, now require carriers to submit parity compliance reports, and all of those states require reporting on all NQTLs. They do not select a subset of those NQTLs. They require reporting on all NQTLs. Maryland's carriers that operate in these states are under an obligation to report on all those NQTLs, and there's no reason for them to have more limited reporting in Maryland. As under the federal law, they are already required to ensure that their NQTLs comply with the law because under federal law, it explicitly states that they are not allowed to sell plans that are out of compliance. So they should have this information already on hand. I want to make one other point because I know this is something that Delegate Cullison was very concerned about during the legislative process and raised it again today. It's the issue of who analyzes these NQTLs, and is this going to impose an administrative burden on the MIA? Well, what the General Assembly did is it has already taken that administrative burden into consideration on the front end because it has limited the number of plans for which a report must be submitted. And it limits that to the 5 most popular plans in the state. Now, in the course of the legislative process, we agreed we compromised on that. We negotiated on that. But that was with the understanding, at least from the consumer stakeholders, that all NQTLs would be reported on. And the reason we thought that was so important was because in the context of your market conduct surveys, the Maryland Insurance Administration has never been able to conduct a full review of all NQTLs. So baseline review is essential. And we also anticipate it's going to uncover long-standing violations. And finally, we do believe that the Maryland Insurance Administration should build on the lessons that it learned from its market conduct surveys and investigations, and what other state insurance departments and attorneys general are also learning. We again included in our written testimonies the 4 most recent examples of what other states have found when they have dug into all these NQTLs. Again, it doesn't, I'm repeating myself, but I think it is so important to emphasize that the MIA found violations of network admission standards, network adequacy practices, reimbursement rate practices, and slower network credentialing for behavioral health providers. None of those NQTLs, I'm sorry, are included in the NAIC form. Other states have identified these exact same violations. Again, just in conclusion, consumers will never have the information needed to put forward a complaint on most of these NQTLs, and they're never going to have the resources or expertise to investigate. As Ms. Middlebrook said, the burden is on the carriers to disclose this information to you, the regulator, and to demonstrate why they comply. And that's what this reporting mechanism will require them to do. So we really do appreciate the care that you're taking in gathering information about this, thinking about what
your obligation is under 15-144. And we again would we do believe that it is sort of what the statute contemplates is reporting on all NQTLs. So thank you for considering our views. We look forward to working with the MIA and other stakeholders on the reporting regulations.
Thank you, Ms. Bride. Appreciate your comments. In the interest of time, I think we're going to move forward just because we have about 50 minutes left and a number of people that want to comment. We do have your written submissions, and that will, of course, be on our website. I couldn't tell if that was somebody from the MIA that had a question or if Delegate Colson had a question.
Good.
Okay. All right, great. Thank you. Again, thank you very much, Ellen. I appreciate your comments. We're now going to hear from Mr. Torsch, Austin Torsch, I hope I pronounced that correctly, Family Peer Support Specialist with the Maryland Coalition of Families.
Yes, and good morning. Thank you so much for this opportunity, and thank you for pronouncing my name correctly. It's usually very hit or miss, but good morning, everyone. Thank you so much for your testimony. Thank you so much for the invitation. My name is Austin Torsch. I'm a Family Peer Support Specialist with the Maryland Coalition of Families. I'm going to try and not repeat too much of what my colleague Ann Geddes had to say. It is my role to support families and caregivers of those with substance use disorders as well as co-occurring. A good portion of my role is supporting the parents of adolescents with whom have these disorders. In my personal experience of working with families, due to a lack of inpatient and a shortage of outpatient programs for adolescent substance use treatment, often what happens is families will have to seek out adolescent psychiatrists with whom also touch on substance use. This has been a new little kind of resource that we've sort of branched out into and has been a widely requested option. However, this has led to another roadblock because of the violation of parity laws and with certain treatment providers. I have heard both directly from families as well as colleagues that children are being put on extensive waiting lists for treatment. This can range anywhere from a few months to even a year. To put things into perspective, a caregiver that I serve had discussed with me in early October that while trying to locate a counselor that would meet her son's specific needs, he had been given a date of March of 2021. Another parent had contacted about 9 separate providers within her network before finding a reputable psychiatrist that fit her daughter's specific needs that had fairly immediate availability. While I understand that everyone wants the best care for their child, it is unacceptable and unjust that someone would have to wait that long to find treatment for their child. I didn't realize how much time we would have or wouldn't have this morning, so I kind of want to keep it as short and brief as possible. So thank you so much for your time and consideration. And if you have any questions, please feel free to either email me, put it in the chat box, and I'll try and answer it as quickly as possible.
No, I appreciate your comments, Mr. Torsch. Very, very well taken. Does anyone from the MIA, Delegate Colson, have any questions? Okay, well, thank you very much today. I appreciate your appearing today.
Thank you.
And then the next person we will hear from is Laura Mitchell, who has a lot of different titles listed. So I'm not going to read them all. I will let you introduce which organization you're speaking for today and provide us with your very impressive background.
Hi, thank you. I'm actually not speaking on behalf of any of those organizations. Most of them I've gotten involved with because of my advocacy work around for my children and others based on my experience. My youngest son very early on experienced mental health issues and attempted suicide at the age of 7. And so again at 9 and again at 11. This was pre-parity inequity, and we were unable to get sufficient care for him and proper therapy, limited visits, things like that. We ended up by the age of 13, he began using substances to dull that pain. At 15, he got hurt and was given an opiate to help that. Quickly realized that that not only helped the physical pain, but the emotional pain. And we started a 15-year trek of active addiction. Trying to find services for him was nearly impossible. As many have said before, we ended up some years later, even as an adult, a young adult, trying to find services was very, very difficult until he was involved in the criminal justice system. Then some things opened up, but we shouldn't have to have our children incarcerated or involved in the criminal justice system before they can get adequate services for mental health and substance use disorders. Because of that and his addiction issues and his mother's mental health issues, who also couldn't get treatment, that's another story, we ended up, my husband and I, raising our grandson, who is now 14. At the time, we lived on the Eastern Shore, and services for mental health in the rural areas are very, very limited. We suspected very early on that he was on the spectrum, and we sought services for that. They did a 20-minute questionnaire. I don't even think it took 20 minutes, actually, in the office and said, no, we don't think so. So we didn't get any services around that. He was 7 at the time. We later moved to the Rockville area where we live now. And fast forward a few years, he began by 6th grade being very overwhelmed with the social issues, the educational issues, just navigating life as he was expected to do more and more for himself and be more independent. And he didn't have those skills. He became suicidal. He did a 2.5-week inpatient stay at a local hospital. And they said very clearly, he is on the spectrum. We know that. We can't do those evaluations here, though. This is an inpatient behavioral health provider, and there was no one here that could do that evaluation for him. We got on wait lists for Krieger and for Children's, both of which were 2 years. We got into Krieger about 3 months ago, but the school had already done the evaluation and confirmed it so that they could begin offering him services. They're not particularly adequate, but he's getting some. We still have not heard from Children's. We're 2.5 years out now and 2 hospitalizations later for similar issues. I'm working very hard with the advocacy and doing all of these things and speaking with MIA and others. Legislators have worked with Ellen Weber quite a bit, and my purpose for doing that is that I don't want his unmet medical needs, my grandson, to end in a path of addiction and substance use as it did for my son. And if we don't deal with those issues now, that's what happens. They find a way to cope, and that's a very dangerous path. I just looked up on my insurance recently because we're having difficulty. His psychiatrist won't see him without being in counseling, which is fine, except that their services at this particular agency don't really encompass autism and people with autism. And so we're looking for other providers to coordinate care with. My insurance lists 50 providers. However, 16 of them are with one agency, which still lists an office 0.8 miles from where I live. But that office closed earlier this year and is no longer anywhere close to us. They're 45 minutes away. They have 2 offices left, but they're 45 minutes away. So that's not a realistic option. Of the others, 3 of them are county programs. So I'm not really sure what the availability of those are. I have calls into all of them, but have not gotten any calls back. And 20 of them, 20 more of those 50 belong to just 3 other agencies. and only 2 on that list of 50 says they accept telemed. And I am very high risk, so we cannot be going into an office at this point. It leads to a lot of challenges. There are discrepancies, as we know, between rural areas, suburban areas, and how much help you can get. Those payment disparities, seeing that 23 to 24% difference in what a provider of physical health gets versus what a mental health or substance use provider is reimbursed for, I think that is largely responsible for what we see, particularly here in Montgomery County, but elsewhere as well. That 2-year wait that we had for an evaluation of the spectrum was 2 months with providers that don't accept any insurance or would be out of network for maybe they accept other insurances. Most of them don't accept any at all because they cannot, it's not a sustainable business model for them to provide services with the low reimbursement rates that they have now. In my experience, I have met through my son's addiction, my therapy for that was advocacy. That's why I'm in this, because that's how I couldn't walk his path for him, but I was going to make darn sure there was one for him to walk and that I would walk it with him as he went. And he celebrated 5 years in recovery on Saturday. So, it's possible, but we shouldn't have to work this hard. Ellen made a comment that consumers don't know when they've experienced a violation. They don't know what they can do about it. And even as involved as I am, I still experience things and then find out later that, oh, that wasn't legal. They couldn't do that. And I have helped many, many other parents fight very hard to try to get services or get coverage for services that their child needed to keep them alive. I can't tell you how many of my friends have buried their children because they couldn't get services and they didn't know that the denials, they failed first, all of those things were violations that they could fight. So we look to our regulators, to you, to make sure that the insurance companies are doing what they are legally and morally responsible to do. And that's what I ask for you to do.
So, Ms. Mitchell, a couple of things. First of all, to you and to many others who are here today, I apologize sort of in advance for not knowing you because, I came into the office in mid-May and I'm learning and getting to meet lots of different people. Can you turn your camera back on again?
Oh. I'm sorry. Yes.
It's okay. Now, I just wanted to take a second to talk to you personally, even though we're kind of in this very public environment. And thank you so much for your courage in sharing your story and your pain and letting us walk for a moment in that pain with you and understanding where you're coming from and what you've experienced. Part of the reason that it's so critical that we have these hearings is that we hear from people like you who can show us on the ground, day in and day out, what's really happening. So a couple of things coming out of this. We're going to have lots of hearings on issues that are big and very detailed and technical, et cetera. And we invite you to come each time to share your story or your specific experiences with respect to that. I would like you to get in touch with me. You could do that through Craig, or you can do that through, probably Craig is the best way, or you can put your information in the chat. You can do it personally to me as a private message. I want to understand more the circumstance you're currently encountering and see if there's anything that we can do with regard to what you've just described with your grandson. I have great empathy for your situation. I'm a former mental health worker myself. Some of my best friends are clinicians. My niece is a mental health worker in Pennsylvania. We have dealt with addiction in my broader and more extended family. So I know how hard your path is, and I'm so grateful that you had the courage today to share your story with us and know that it's heard. Just know that it's heard. And if you'll send me your information, let's see what we can do to help you with what you're experiencing right now.
Thank you.
You're very, very, very welcome. So we thank Ms. Mitchell for her candor and for sharing that information with us today. And we now invite Dr. Stephanie Nahr to speak.
Hi, how is everyone? Can you hear me?
Yes.
Okay, great. My name is Dr. Stephanie Nahr. I'm a licensed clinical marriage and family therapist in Maryland, and I'm a owner of a growing group practice. So essentially in private practice, but with some therapists working for me as employees, so I can, help them to see clients as well. I would like to briefly comment on 3 practical solutions and qualitative ways that I believe that is affecting mental health, basically services for the community. The first thing, well, actually all the things I'm going to comment on, I think really speak to the fact that the way that the current regulations are within mental health are really tying the hands of leaders in mental health. And I'm going to explain why. I see myself as a leader because I've been in the field for 20 years. I have a PhD in the field, and, I own a group practice that is growing slowly. It could grow much more quickly if I had if there were different policies in place. I'm from an entrepreneurial family. My father started a manufacturing company that's nationwide now, and my siblings are now the owners of that company. I would like the opportunity to service Maryland clients better, including teenagers. But as you've heard from other people who have testified today, there are many difficulties in being able to do that as a business owner. Now, as a leader, one of the prominent ways that I see my hands being tied and is not the same in the medical field is that interns and residents, we are not allowed as a clinical supervisor to bill for their work if we are supervising them. We cannot bill to private insurance, we cannot bill to state Medicaid, and we cannot bill to Medicare. This is not the same in the medical field, okay? I've spoken to my friends who are physicians, even those in outpatient settings like myself. If they're a specialist, let's say in radiology, or they're a specialist, one of my friends is a rheumatologist, another one's a neurologist. They are allowed to have interns and residents work under them so they can teach them, so they can help those new professionals in the field to grow. And then as they're observing and supervising their work, then they're allowed to bill for those procedure codes as the clinician. We are told in mental health that we are not allowed to do that. Some practices who have done it, I think, maybe either not knowing or just because it's so frustrating to not be able to do it, have gotten in trouble for doing that, is my understanding. I cannot wrap my head around the reason for this, and it creates 2 problems. First of all, there are interns trying to find internships, desperately trying to find a place to work when they are in school, when they are doing their master's degree. We have all these people you've heard seeking services. I know for a fact, because I have clients sometimes who reach out to me who are so thankful that I have a business that answers the phone or gets back to them quickly and schedules their appointment, because they have called around and spent 3 days trying to find an appointment. So why on earth would we say we can't bring new interns and residents into the field and teach them and allow them to see patients and help with some of the mental health burdens that people have, and give them opportunities? As a business owner, I have always had one intern every school year, but it's really out of the goodness of my heart, because it's actually a huge pain in the neck. And the reason why is because most patients want to use their insurance because they're paying large amounts of money for their, their insurance deductible, their monthly payments to be an insurance subscriber. And so they want to utilize it. And so if I say, well, you can see my intern, let's say for $50 an hour. Nope, they're going to call around and try to find someone in network. So it really does affect, in my opinion, you know, the opportunities for young professionals. I would love to have 2 or 3 interns every semester, teach them what I know, have them working with children and teenagers. But I logistically just could not do that because our hands are tied in this way. The second, the one other comment I would make when I speak to residents. So residents, I'm considering as licensed graduate professional counselors or licensed graduate marriage and family therapists. These are professionals who have just graduated, and then they have about 2 or 3 years where they have to work under clinical supervision. Very similar in the medical field. When you graduate, you're a resident for a little while, you still work under the supervision of a much more experienced doctor. Care First, in January 1st of 2019, began allowing us to bill for residents. They allowed residents to become credentialed so long as they have a supervisor, and that is what has allowed me to actually grow my business over the last 1.5 years. Before that, I was a solo practitioner. There was no way for me to grow a business effectively because it was too difficult with the low reimbursement rates and the fact that we cannot bill for interns and residents and kind of get them starting and teach them what we know and then allow them to continue to grow their clientele, if that makes any sense. So I feel like Care First really is the leader in terms of starting to fix this problem where they're allowing the residents. I really wish the other insurance companies would get on board because that would be super helpful. And we have these young professionals who are eager to take on more clients and work and learn, and they're not being allowed to do so. Care First is the only provider that I'm aware of in both the public and private healthcare sector that is allowing that to happen. I really feel like this is such a necessary change, and it's really why the medical field is allowed to grow, and that's a huge difference in my mind between medical versus mental health parity. I'm not sure if that, I don't know all the laws, so I'm not sure if it meets all these laws or regulations you're talking about, but I just want that to be changed. I've actually reached out to 2 legislators and asked them to introduce legislation next year for that to change. I'm not sure how that works, if legislation would need to be introduced or policy would need to change, but I'm pretty much not going to be quiet about this. Like I had a whole bunch of clinicians sign a petition this summer. I sent it to the commissioner. I really think that this needs to change for us to really become more effective. The second thing, really quickly, because the other 2 things have already been commented on, so I'm just going to be brief with these other 2 things. But the second is that some healthcare plans, and I think Ms. Weber commented on this, some healthcare plans limit in-network providers. For example, Cigna. I have tried to apply to be a provider with Cigna on 2 or 3 occasions in recent years since mental health parity regulations, and they will not accept new providers. They will tell you they already have enough providers. However, I have friends, family, people that I know, clients who come in and they're frustrated because they're using their out-of-network benefits with Cigna, right? Because they cannot find an in-network provider. So Cigna is basically, in my opinion, how do I say this, is being deceptive when they're saying that, they already have enough providers. They do not have enough providers. And furthermore, they're the only insurance company I know who limits providers and will not allow them to even sign up. Like Care First, Aetna, some of the other ones, if you want to be a provider, you just submit your credentialing application and pretty much they will accept you for the most part. And they have a fairly large share of the marketplace. So if you're hearing from constituents or employers, if I was going to advise employers on, which insurance companies to sign up for if they want their employees to have mental health, it would not be Cigna, okay, because of that reason. It would be Care First for the reason I already gave about interns and residents. The third is that the healthcare plans do have low reimbursement rates. Again, Care First is the leader on this. Their reimbursement rates are starting to get to the level where I can make a small profit and it's worth my while to actually have a business and have overhead costs. Just to give you a quick example from a business perspective, whether you have a master's degree or a PhD, you will get paid the same, which is also, I think, a parity violation. But if you have a master's degree and you primarily work for Cigna, Aetna, United, and most of the other insurance companies, including Medicare, and you see 30 patients a week, which is pretty standard, it's a pretty busy caseload, you would make about $95,000 a year. Not profit, that's gross. Just if you're all by yourself, sole proprietor. If you add in all of your overhead costs, you're going to make, by the time you pay your liability insurance, your office space, all these different things, about $70,000 to $75,000. This is why people do not accept all these insurances as in-network, because the strain of the vicarious trauma, compassion fatigue, dealing with all the issues, working, by the time you service all the clients and run your business, you're working 50 to 60 hours a week to make $70,000 a year. There is no other professional with commensurate education with a master's degree or PhD that makes that kind of money. So in summary, my three suggestions are for there to be legislative and policy action that quickly changes the regulations and rules around interns and residents being able to be billed by clinical supervisors so we can grow professionally and service more clients. The second, to actually do some business-minded research on what would actually clinicians need to be paid, especially leaders, that would be fair and commensurate to people with similar levels of education so that they can run and grow their business so we can actually service people. Because until you allow business owners to actually, have enough money to work with to have cash flow and grow their businesses, we're going to continue to have a lot of sole therapists out there working all by themselves. And even we do not make enough money to have a receptionist to answer our phone. That's the other thing. That $70,000 that I gave you, that's without a receptionist. So people are calling around and they can't speak to a doctor or a therapist because we don't have a receptionist because we can't afford one. And while we're paying our student loans that we had to pay to get the commensurate education, it's just very frustrating. The final thing is then to, have a method whereby providers can report insurance companies for limiting them and not allowing them to be credentialed, such as in the case that I gave you with Cigna. And there are a couple other smaller insurance companies that do that as well. Because it's not really, in my mind, that's a violation to the rights of the consumer. Thank you for your time.
No, thank you. I do appreciate it. And, as I mentioned a few moments ago, I have a niece. Now, she's not in Maryland. She's in Pennsylvania. But she is a recent graduate of Drexel. And so is going through that process. And I feel like I've just hung up from a conversation with her with her levels of frustration, checking off a lot of those points. So plus she has to pay for supervision. So
really it's you get out of school and you can make because if you consider this as, as a business owner, I can make about, $70,000 to $80,000 off hiring, from the insurance company, gross income to have someone work for me. I can only pay them $40,000 out of school with a master's degree, and they work. People do it. They just work for that. It's like slave labor almost. Not quite, obviously, but by the time you pay your student loans and everything, you're really in it for the heart of wanting to help people. But that only lasts for so long when you're trying to pay bills and possibly start to have a family and raise children.
No, we appreciate your sharing your comments today. Thank you very, very much. I believe that we have so far, Craig, I think you've identified 3 folks who have identified themselves on the chat line who want to be heard.
That's correct.
Today, okay. So I will, if you don't mind, if you want to lead us through whatever order they came in.
Yes, absolutely. And the first is Darcy Smith of Care First, and I will unmute her now.
Great, thank you. Hey, Darcy.
Hi, actually I had withdrawn my request, but thank you.
Okay. Next is Matthew Celentano of the League of Life and Health. Let me find Matthew.
Matt, are you there?
1 second. See if I can find him. Here we go. And he's now unmuted.
Good afternoon. How are you, Commissioner Bahrain? Thank you very much for the opportunity to speak real quickly. I'm going to be brief because it's been a long hearing. But first and foremost, I wanted to thank the MIA and the MI's team for being real partners through this legislative journey that we took this past abbreviated legislative session. Although it might have been abbreviated, we spent an enormous amount of time on this piece of legislation, and it was a collaborative process. I cannot thank enough Delegate Kelly and Delegate Cullison and Senator Augustine for their leadership sort of shepherding us through this process. It took a lot of effort, and it was not the most pleasant legislative journey, but it required a lot of give and take, which sort of led us to the result, which was House Bill 455. I think that I just wanted to speak up real quickly because I wanted to let you know, and I think you already do know, though, that the carriers are going to be engaged in this process. We will continue to be a part of these work groups and provide any information that you see fit. But one thing that has kind of came up over the course of this hearing is that there was sort of a desire for standardized forms and formats. And I think that's part of House Bill 455 was when we had all sort of compromised on the fact that we would use the NAIC standardized tool moving forward. And we also talked a lot about how there was going to be not one but two reports. So there was an opportunity once we had established the first set of data, if there were compliance issues, that the carriers would be able to go fix it and take additional steps forward. So that being said, we will have a lot more to say. We will submit written testimony at some point, but we wanted to thank you so much for including us, and we will be engaged in the process through the end of this year and through 2021. Thank you very much.
I appreciate that, Matt. Thank you for jumping on. We know that you have reached out and indicated your willingness to work with us and to participate in work groups. And as I said, this is going to be a very transparent and robust process, and this is the first of what will be many hearings and many opportunities. So thank you for confirming your engagement.
Thank you, Commissioner.
Craig, I think we may have had one more person.
We do. Lisa Haywick of Psych Associates of Maryland.
Thank you.
Hello, hi. Yes, my name is Lisa Hewick. I'm the Chief Quality Officer and a mental health therapist at Psych Associates of Maryland. I oversee our credentialing and our billing department. For Psych Associates of Maryland, we have 6 locations. We're in 5 different counties. We serve children, teens, adolescents, geriatrics, and families. Some of the services we provide is therapy, psychotherapy, neuropsychological testing for children and adults, ABA services for children with autism, women's services, and also we began working with veterans. Thanks for giving me the opportunity to discuss our experience and our concerns today with insurance companies. We have a few major concerns that involve credentialing, allowance for procedure codes, and billing reimbursement. These issues have presented a barrier for us in providing mental health services and just making them accessible. We've had an increase in referrals due to COVID, and due to the increase, we've also had an increase in hiring of mental health professionals. When a provider comes on, the first step of the onboarding is credentialing. One of the big barriers we're facing is that the credentialing is taking a 2 to 3 month period, which is also making us have a delay in serving the patient. We have a wait list that actually is weeks long. However, we'll have providers that that have availability and could see the patient, but due to the credentialing, we're unable to match them. We also this is also causing not just for patients, also a financial concern for our company due to having to pay providers and not being able to bill for services. We work with 12 different insurance companies, and only 2 of them are allowing us to begin seeing patients as the date that we first apply. Those 2 are CareFirst and Johns Hopkins. We also are having some issues with the credentialing in regard to just getting correspondence on the process and getting updates. Recently, we did have 2 providers that were dropped from Cigna who actually began seeing individuals and then had to transfer their patients, which caused the problem. The reason we had for that was that they were licensed master social workers, which is the LMSWs, and they said they did not credential them. And as was said already, the only one that we are aware of that credentials is Blue Cross. However, we did find that United Healthcare has a group addendum that we're working on in order to try to get permission to bill with the LMSW or LGPC. Again, we have these providers that have open availability, yet we have a caseload, a wait list, because we are unable to bill for these services. Second major concern is getting reimbursement for specific services. We are also taking more patients and having more providers, but we're also expanding services. Some of the services we tried to add, or we would like to add, is providing nutrition services, which would require a dietitian. Recently, we hired a dietitian. However, she was unable to get credentialed with all 12 of the insurance companies, which ultimately we lost the provider. The second was a pharmacist. We hired a pharmacist to be on staff. However, he was unable to get credentialed, and I imagine that was due to being in a private practice, private mental health facility. Another issue that we're having is providing DBT therapy services. And this type of therapy requires longer sessions that are more frequent. There are no codes in order to reimburse, so these individuals are forced to pay out of pocket. And that goes along with if we had a dietitian or a pharmacist on staff. Then in regards to psychiatry, we are providing Spravato, which is medication treatment for depression, and it helps individuals with suicidal ideation. However, they're not allowing us to build G codes, which again is making it this service, or forcing individuals to pay out of pocket, which now they're self-pay. The third major concern is the low billing reimbursement rates. We have been corresponding with the insurance companies. However, we don't always get correspondence back, and we have not been able to negotiate rates with individuals. Actually, right now, we're working with Aetna. The last correspondence we had was from October 2019, and we have not heard from them. And there's been some other insurances that we have record that we've been trying to get an increase since 2013. So kind of to summarize some of our concerns, we would like to have more updates on the credentialing process, to be notified if someone is going to be dropped for credentialing or if there's an issue ahead of time, possibly allow the LMSWs, LGPCs to bill and receive reimbursement. Also to consider allowing services to approve services based on the individual need or medical need versus just like a blanket, it's not covered, as for example, the dietitian. Then also the time frame, I'm not sure if there is a policy already in place, and when you attempt to negotiate a rate, like how long is it that we should expect a correspondence, or if there's some sort of guideline in the amount of time. And then in regard to deciding if we can get an increase in rate, considering the number of patients that we see and the time that we've been contracted with the company.
So I want to thank you for those comments. I mean, one of the things that we have to do sometimes, and I fully understand and appreciate that when we provide an opportunity for comment, it gives you a place to be able to express a number of issues that you're experiencing, and we do want to hear them, and they do have to be parsed out. Not everything relates specifically to parity, which is what we happen to be focusing on today. But you've also raised issues with regard to network adequacy, and we will keep them in mind because at the same time, and we will be having a hearing in mid-December to talk about our proposed regulations for network adequacy. And fortunately, we do have on the phone with us today Delegate Colson, Senator Eckert, who we're going to hear from in a second. Senator Augustine has been on the line as well. And I think that this provides you with an opportunity to share with them some of the broader concerns that may not fit neatly within our particular subject matter today, but you do provide context and perspective. And so we thank you for that.
And Kathleen, if she could reach out to me this afternoon or this week, I'm happy to discuss her issues at greater length and whether we can address some of them.
Oh, I appreciate that.
That's great. If you can see Mary's information there, if you want to send her a private chat as well with your email address. And I think we have your contact information, Mary. I'll make sure you get that if you haven't gotten that.
Okay, thank you.
Thank you so much. I know that Senator Eckert wanted to speak as well. So, Craig, have you been able to make her a participant?
Yes. Thank you.
Senator,
Thank
I'm very
you,
happy to have you
Commissioner.
today.
Thank you very much. Thank you for the opportunity to just say a few words. I just can't tell you enough how appreciative I am that you've undertaken this to really look at the parity issues. There are many complex issues facing us for a very vulnerable segment of our population, those who struggle with substance use disorder and serious and persistent mental illness, as you know. And as we are faced with the pandemic, I am concerned, as others are, that this is just going to increase. And now we're hearing more about the long-term effects of COVID on those who have already had it. So we are going to have to beef up our services and streamline our regulations to be able to make sure we have a robust workforce to be able to meet these needs. From my years' involvement in psych, and I still dabble in it, as you well know, it's just very important that we're able to treat the brain as we treat the rest of the body, because I think once we get that integrated, we will see more efficiencies in our service delivery, but we're not there yet. So thank you for your passion. Thank you for bringing the group together and opening these conversations so we can make the changes that we need. And I'm certainly glad to stand by and work with you in any way I can. Thank you.
Thank you, Senator, for your leadership on this issue, for being here today, but also for all the good work that you do with the Governor's Commission and on this subject generally. So we are happy to partner with you on this topic and really on mental health services more generally. Dr. Colson, was there anything else that you wanted to add today?
I just wanted to add my thanks as well to the participants, but also to you, Commissioner, for convening this first hearing and as we move forward on this really important issue. And I know, and I will confirm and affirm what you said about us listening to all of the issues that were presented today, those that are related to go beyond parity, but we certainly are also very interested in making sure that we meet those parity standards. So thank you, and I look forward to participating and continuing this work.
Absolutely. So I wanted to just make sure one last time, Craig, whether there was anybody else that had indicated a desire to speak.
There's no one else in the chat.
Okay. Well, in that event, thank you very much for everyone that participated with us today. I think this was an extraordinarily useful session. In addition to the professional expertise that we heard, it was also so important for us to hear from individuals and from providers and really everybody across the spectrum. While, as Delegate Colson also noted and Senator Eckert also noted, not every single thing relates specifically to parity. There are a lot of issues that have to be addressed, and we're happy at the MIA to provide a forum for people to share their thoughts. The recording of this virtual hearing will be posted to the MIA's website, together with all comments and presentation materials. If you have not had the opportunity yet to submit comments on today's topics, but you would like to, you are welcome to do so. You can use the same portal that's listed on our website. So if you go to the MIA's website, you'll see under the quick links the advertisement, if you will, for the notice for this hearing. That portal is still open to receive any written comments that you'd like to post. We will be hosting additional meetings on the proposed regulations. Those meetings and topics will be posted to the MIA's website and sent out to our various email lists as well. Thank you all for your participation today. I wish everyone a very safe and a very happy Thanksgiving holiday. And just please remember, wear your mask, wash your hands, watch your distance. Take care. Thank you.